So without further ado, let's kickstart the program. The first program is the workshop on stroke imaging, basic and advanced, a case-based step-by-step approach, which is being moderated by the head of Department of Neuroradiology at the All India Institute of Medical Sciences, Professor Shailesh Gaikwad. I'll hand over the mic to Shailesh, sir.
Good afternoon, everybody. My panelist, and it is a great honor to be part of the Stroke Summer School 2021. And at the outset, so good afternoon, everybody, and it's a great honor to be part of the Stroke Summer School 2021. At the outset, let me thank Dr. Padma and Dr. Rohit for inviting me in this August gathering. So without wasting my time, I think we should immediately go on to the first session of this meeting, which is on workshop on stroke imaging, basic and advanced, case-based, step-by-step teaching. And I invite my colleagues from the department, Dr. Ajay Garg and Dr. Levi Joseph, to begin.
Thank you, sir. At the outset, I would like to thank Professor Padma and Professor Rohit and Indian Stroke Association for inviting me. Over next 35 to 40 minutes, I will be talking about basics of the stroke imaging. I'm including both ischemic, hemorrhagic, and other causes of the stroke, which is I've seen the program of the workshop. So I'm including all those topics. Let's look at the first case. The first case is a 35-year male who presented with right hemiparesis of the duration of last 6 hours. But when we look at the plain CT scan, the role of CT is first to rule out hemorrhagic stroke. Second, the role of CT scan is to look for the extent of the early ischemic changes. Like in this case, we see hyperdense middle cerebral artery on the left side. If you see the section at the level of the basal ganglia, we see there is obscuration of the lentiform nucleus. On the right side, we can see the lentiform nucleus outlined well. The caudate is also well seen. Here, the caudate is hypodense compared to the contralateral side. The lentiform nucleus outline is not seen. On the right side, we can see the outline of the insula, which is also not seen on this side. So these are the early ischemic changes. There is an obscuration of the lentiform nucleus, the loss of the caudate signal intensity, and the insula is not seen. So in this case, the MR was also done. In MR, I just want to describe the MR finding in acute ischemic stroke. In MR, we'll see the changes which are limited, which are seen involving both green and white matter. Like in this case, we see involvement of the both cortical structure plus the deep gray matter involvement. And these areas are bright on diffusion weighted images and dark on ADC map. So that suggests there is a restricted diffusion. If we do this, MR angio was also done in this case. That shows occlusion of the left ICA. What we see only the small stump of the ICA. The distal ICA, the MCA on the left side, they are not seen. So this is left ICA occlusion. And on DSA, what we see the small stump of the ICA that shows it, and there's a distal ICA is not seen. That is suggestive of ICA dissection. So what in this case we see vascular imaging and parenchymal imaging, which shows left right is dissection. There's a dense MCA sign, plus there are early ischemic changes which are seen on this. Let's look at the second case. This is 32 years male present with right hemiparesis of the duration of 3.5 hours. So we have to look for the early ischemic changes. We have to look for the direct thrombus if we can see. These are the sections taken at the level, in the upper row, the sections were taken at the level of the M1 vessel, and in the lower row, the sections were taken at the level of the basal ganglia. If you look carefully, the left side of the middle cerebral artery is hyperdense compared to the contralateral side. Plus on the left side, the basal ganglia structures are also not very well defined. If you want to see the basal ganglia structures, we should change our window setting. If we use a narrow window setting, we can see this differentiation very well. Like in this case, if you look carefully, the left side of the basal ganglia structures are not seen compared to the contralateral side. So these are the early ischemic changes, very well seen on CT scan. If you change a narrow window setting, you can see them well. So you can see the direct thrombus in the form of the MCA occlusion, plus you see this. The CT angio was also done, which shows a small stump with tapering. So what is the site of obstruction in this case? Is the obstruction at the level of the ICA origin, or it is distally somewhere in the distal ICA or at the T junction or MCA? If you look carefully in the base images, we can see that the ICA is distended and it is not opacified. So what we see, the non-opacification of the ICA. That can happen when there is a distal ICA occlusion, and then one should be careful to find out the site of the ICA occlusion. In this case, the DSA was done. A DSA clearly shows there is occlusion is at the level of the supraclinoid ICA. So one should be careful while interpreting CT angio to localize the site of obstruction. When there is a complete obstruction at the proximal level, then in the early phases, because of the slow flow, we are not able to see the distal thrombus itself. The occlusion will be seen proximally. One must be careful in this. Let's look at the third case. This is also 45-year female with right hemiparesis with aphasia of 2 hours duration. If you look carefully, the images looks more or less normal, but if you change the window setting, you can clearly see the left side of the basal ganglia structures are very, very well lit. So based on, I'm showing the multiple cases just to emphasize that you should always look your CT scan images on a computer, on a workstation, and try to play around with the window to see the acute stroke ischemic changes. On CT angio, you can see that this focal stenosis narrowing is seen in the distal M1 segment. Another patient, 30 years male with altered sensorium quadriparesis of 2.5 hour duration. Here, if we look at the basilar artery is hyperdense compared to the hyperdensity of in the region of the MC. So it's a dense basilar artery, and then on DSA it clearly shows there is occlusion of the distal basilar artery, which can be treated with thrombolysis. Let's look at another patient. Is a 45-year female who is having right hemiparesis, duration of 3 hours. If you look at the basal ganglia structures, they are very well seen. Even on the different window setting, there was no early ischemic changes were seen. What else could be there? If you look at the Sylvian fissure on both sides, you see the focal area of hyperdensity in the left Sylvian fissure. This is the thrombus in the distal MCA branches, which is appearing hyperdense. So this is known as MCA dot sign, which can be seen in distal MCA occlusion. In this patient, this was confirmed on CT angio where the distal MCA branches were not seen. Even on the DSA, we can see there's a cutoff of the distal M2 branches. This patient is a 31-year female who is a known case of rheumatic heart disease. She has aortic valve replacement in 2016. Now she presented with the struck valve for which she was treated with warfarin. Following admission, she is now complaining of nausea, vomiting, dizziness, and headache for 4 hour duration. If you look carefully in CT scan done at various levels, there is no single change seen in the region of the pons or cerebellum, but you look at the density of the basilar artery. The distal basilar or the proximal basilar artery is isodense. When you go up, suddenly the signal density of the basilar artery changes. This is because of the presence of the thrombus in the basilar artery. On the CT angios, we don't see the distal M4 segments, and the whole of the basilar artery is not seen. This is also because of the proximal occlusion that the whole of the basilar artery is not seen. On CT angio, we can clearly see the occlusion is not in the whole of the basilar artery, only the distal 1/3, or there is a T occlusion of the basilar artery. And on CT angio, it is overestimating the site of the degree of occlusion. This is a case of acute infarct in the region of the right MCA territory, left MCA territory, which is involving both gray and white matter. If you look carefully on the CT angio, on the DSA, we can see the tapering of the proximal ICA. That is suggestive of ICA dissection. If you take axial sections through that, you can see the thrombus within the wall of the vessel. So just to summarize, we should look for the early CT signs which are diagnostic of the ischemic stroke. First, we can see the hyperdensity in the MCA. We can see hyperdensity in the basilar artery. This is around 50% sensitive, but it's quite specific for the thrombosis. These patients respond very well to the mechanical thrombectomy. Then we can have the MCA dot sign, which can be seen as a dot in the Sylvian fissure because of the presence of thrombus in M2 branches. Then we can have the obscuration of the outline of the lentiform nucleus, which is one of the earliest sign. Then we can have the obscuration of the insular ribbon, like on the right side we can see the insular ribbon well, but on the left side the insular ribbon outline is cannot be separated from the external capsule. And then we can have the loss of gray white matter differentiation and sulcal effacement. So these are the signs of the early ischemic changes. The second role of CT scan is to look for the extent of this signal. How much is the area of MCA territory or PCA territory which is involved? Just to then one should be careful to differentiate this dense MCA sign from the pseudodense sign. In cases of polycythemia, dehydration, or vascular calcification, we can see the hyperdensity of the middle cerebral artery as a normal finding. But in such cases, the findings are usually bilateral and it involves the multiple vessels. The second role of CT scan is to know the extent of the these early ischemic changes, so that we can predict the risk of hemorrhagic transformation. For this, in 2001, Alberta's stroke program early CT score was proposed, which is a 10-point topographic scoring system in which the MCA territory is was divided into 10 regions. For normal MCA territory was assigned 10 points, and each point is deducted for each area of involvement on NCCT. If you look at the MCA is divided at two sections. One section is taken at the level of the basal ganglia, and second is at the level of supraganglionic region. We divide MCA into 6 cortical regions: M1, M2, M3 at the level of the basal ganglia, M4, M5, and 6 in the supraganglionic region. Plus, we give 1 point to the caudate nucleus, 1 for the lentiform, 1 for the posterior internal capsule, and 1 for the insular ribbon. Each age, like in this patient, this M1, M2, M4, M5 plus insular ribbon is involved. So the aspect score is 5. When the aspect score is 7 or less than 7, those patients have a poor functional outcome following any intervention. Let's look at this. Is a patient of 88-year female who is found down and unresponsive. This is a classical imaging finding. What we see, bilateral symmetrical involvement of the medial thalami, which are dark on ADC, suggestive of diffusion restriction. This is a case of artery of percussion infarct, which is a common trunk which arises from the PCA from P1 segment from either side. A patient present with bilateral paramedian thalamic ischemic lesions. Let's look at this patient. This patient is having bilateral symmetrical changes involving the temporal lobe, involving the deep and subcortical white matter, external capsule. If you look at the clinical presentation of this patient, this is a 38-year lady who presented with worsening diplopia, left hand weakness, and slurred speech. And she's also having progressive cognitive decline. You look at the imaging finding, these imaging features are suggestive of CADASIL, where you see involvement of the temporal poles, involvement of the external capsule, the bilateral symmetrical involvement, which appear bright on T2 and involving the subcortical and periventricular white matter, mainly in the frontal, temporal, and insular region. In addition, we can have multiple areas of hemorrhage or multiple areas of focal diffusion structure in cases of the CADASIL. This is a 79-year-old man who presented with loss of consciousness. Whenever you see case of hemorrhagic stroke, the aim of imaging is to confirm the diagnosis, plus know the extent of hemorrhage, whether this patient is a surgical candidate, or can we predict the etiology of the hemorrhage. Like in this patient, the hemorrhage is limited to the region of the basal ganglia with intraventricular extension, causing midline shift and hydrocephalus. So this is classical presentation of hemorrhagic stroke because of hypertensive bleed, which is causing herniation, descending transtentorial herniation, and midline shift. So if you look at the location of the hypertensive hematoma, is the most common cause of non-traumatic cause of ICH. It is predicted in the areas of the basal ganglia involving the external capsule and putamen, then thalamus, pons, and the cerebellum. These are the 4 common locations of hypertensive hematoma which can be picked up on imaging. On MRI, the acute hematoma may be difficult to differentiate. This may appear as areas of bright signal intensity and diffusion weighted images, dark on ADC. But if you look at your GRE sequences, you will see a thin hypo-intense rim that will suggest the diagnosis of hematoma. Plus, you can see the fluid level within the occipital horn or the body of lateral ventricle suggestive of hemorrhage. Hypertensive also cause hypertensive arteriopathy. We see multiple focal areas of hypertensive bleed, which can be seen in the region of the basal ganglia, plus pons, with in addition to white matter signal changes, which are bright on T2 weighted images. Plus, we can have focal areas of diffusion restriction. So these are the classical changes of hypertensive arteriopathy, which has got distribution in the region of the deep gray matter structures. Let's look at this case. This is a 40-year male presented in emergency with left upper limb weakness for 4 days and right lower limb weakness for 3 days. And what we see an area of focal hemorrhage. Whenever you see a case of hemorrhage on NCCT, look for whether this hemorrhage is single or multiple. Like in this case, the hemorrhage is seen on the right side, plus there's a focal areas of hemorrhage is also seen on the left side. So this is a case of multifocal hemorrhage. What is next? We always look at your sinus density. If you look carefully, this sigmoid sinus looks normal, but if you look, goes proximally, this right transverse sinus is hyperdense. And if you look, seen in the region of the suicidal sinus, that's it also hyperdense. So sinuses are hyperdense, plus there's a hemorrhage in both sides of the brain. So that is suggestive of superior sagittal and right transverse sinus thrombosis. So in cases of the bleed, we should always look at the density of the venous sinuses to confirm the diagnosis. So how to differentiate venous infarct from the arterial infarcts? The venous infarct will have variable distribution. They are appearing as a patchy lesions, which are more seen in the region of the white matter than gray matter. They are commonly hemorrhagic. The venous infarct shows areas of hemorrhage on day 1, day 2. On the other hand, the arterial infarct was hemorrhagic transformation mainly in the later phase. And the white matter hematomas are much more common in venous infarct. On the other hand, the arterial infarcts are mainly cortical in location. And the venous infarct will have pronounced mass effect and edema. And always, whenever you see, try to look for the venous clot within the sinus. Like in this case, the suicidal sinus is hyperdense, suggestive of acute clot within the sinuses. Suppose the sinuses are not, this thrombus is not acute, then you may not see the hyperdensity on a plain scan of the blood clot. But if you give contrast, it will appear as a filling defect. That is known as empty delta sign, which is seen in venous sinus thrombosis. The normal sinuses will show enhancement, but in cases of the thrombosis, it will appear as a filling defect. And if you look at your MR scan, there will be loss of the flow wide. Normally, the sinuses appear dark on T1 and T2 weighted images, but in cases of sinus thrombosis, that hypointensity is lost. It is appearing iso intense in these images. So these features suggest venous sinus thrombosis. So in cases of the raised pressure, whenever you are looking at your MR scans, look at the sinuses first. What is the intensity of the signal? Whether the flow wide is maintained or flow wide is lost? Or what is the density in cases of CT scan? If it is isodense, you can give contrast and look for the filling of the sinuses. Like this is the normal dural venous sinuses. They are appearing dark on T2 flare and other images. This is the flow wide which is seen normally. The normal gray white matter differentiation is well maintained. But in this case, like this is the case of subacute venous sinus thrombosis. The thrombus is bright on both T1 and T2 weighted images, and you appear as on MRV, you can see this filling defect suggestive of thrombosis. This is another example. If you do SWI, because of the venous congestion, the veins appear very prominent in venous sinus thrombosis. These are one of the early findings which can help us to pick up venous sinus thrombosis. And contrast, there will be no enhancement of the sinuses. And this is the case of MR venogram, shows the distal suprachiasmatic sinus is not opacified. Whenever you see a case of posterior temporal lobe bleed, always think of venous sinus thrombosis. Like in this patient is having a large area of bleed in the posterior temporal lobe on the left side. If you look at the suprachiasmatic, look at the sigmoid sinus, the sigmoid sinus shows loss of flow wide. So that is a history of sinus thrombosis. On MR venogram, we can clearly see the left transverse and sigmoid sinus, they are not opacified. So this is a case of sinus thrombosis. So the message is, whenever you see a case of temporal lobe, especially the posterior temporal lobe, always rule out venous sinus thrombosis. Let's look at these images. What we will see is hypodensity in the region of the bilateral basal ganglia structures, which is asymmetrical, much more on right side than compared to the left side. In such cases, look for two things: whether any area of hemorrhage is there or not, and what is the single density of the deep venous system. Like we can see is, in this case, we can see area of hyperdensity in this region of the caudate nucleus. That suggests there is a bleed in this region. And look at this bilateral internal cerebral veins plus this sagittal sinus, straight sinus is hyperdense. So that suggests there is a thrombus within it. This patient is a 28-year female postpartum 20 days, presented in casualty with history of left hemiparesis. So these are the differential diagnoses whenever you see bilateral basal ganglia involvement, deep venous sinus thrombosis, Japanese encephalitis, rarely herpes or thalamic glioma. So always look for the areas of hemorrhage or look for the single density of this deep venous system. Similarly, this is the MR example of the deep venous sinus thrombosis. What we see in one of the deep gray matter structures, both on T1 and T2. In T1, we can see areas of hemorrhage, which is very well seen on this gradient sequences. And on MR venogram, the deep venous system is not visualized. This must be differentiated from the Japanese encephalitis. We will see bilateral involvement of mainly the thalamus plus the substantia nigra. But look at the sinuses, deep venous system. Here the deep venous system flow wides, they are very well maintained. There is no hyperdensity on this T1 weighted images. These are the things to look for. Let's look at this patient, another patient who presented with headaches. What we see, the sulcal hyperdensity in the region of the cerebral convexity. What are the differential diagnoses of the convexity assay? This can happen in suprachiasmatic sinus thrombosis. This can happen in atrial myxoma, posterior reversible encephalopathy syndrome, cerebral amyloid plus infective endocarditis. So for thrombosis, always look at your sinuses. In this patient, the sinuses are hyperdense. That suggests this is a case of suprachiasmatic sinus thrombosis presenting as sulcal assay. This was also confirmed on BSA where the suprachiasmatic sinus is not opacified. Similarly, the atrial myxoma can present with multiple bleeds in the parenchyma plus sulcal SAH. In this patient, the DSA was done, which showed multiple pseudoaneurysm. It was confirmed on echo. There was a mass in the right atrium, which was biopsied and turned out to be atrial myxoma. The atrial myxoma can have also multiple parenchymal plus sulcal SAH. This can also happen in infective endocarditis. This example of bilateral, this posterior reversible encephalopathy syndrome, where you will see changes which are limited to the right occipital region, frontal region, mainly in the watershed areas, plus you can have sulcal hyperdensity suggestive of SAH. And then cerebral amyloid angiopathy can have multiple sulcal bleeds, where the hemorrhages are mainly limited to the subcortical white matter. The multifocal, compared to the hypertensive encephalopathy, the deep gray matter structures are not much involved. The bleed is mainly limited to the subcortical white matter. Then
we can make this, can I interrupt? We can make this more interactive, right? So we can invite questions from the students and maybe from the other participants.
This is a case of diffuse SAH because of the aneurysm in the cases of the MCL. In cases of this, diffuse SAH should be differentiated from pseudo SAH, which can happen in cases of diffuse brain adhesion. Okay, I will invite questions Any resident who want to read this case?
So anyone who wants to come forward. So, okay, Ajay, you can go and describe the findings first and then we invite the patient.
This is 60-year female presented with vomiting followed by loss of consciousness 1 day prior. What we see areas of hyperdensity on the CT scan with a density suggestive of acute hematoma, which is seen in the region of the temporal lobe. Is it hypertensive bleed? The question is it hypertensive or something else?
First, the location-wise, it doesn't fit in the classical hypertensive area, sir. Plus, I don't know the BP of the current BP of the patient, the presentation BP of the patient.
The first question is whether this is purely parenchymal or there is a bleed in the subarachnoid system, like the Sylvan.
Yes, sir. It is in the last image we can see it is sipping into the subarachnoid spaces, sir. And there is a much perilisal edema also.
Okay. What is this image? The second image?
It is into the Sylvian fissure, sir. It is merging into the Sylvian fissure, sir.
And
What about the supra
Basal system, also in the basal system, sir.
It is in the suprasellar system. And look at the shape of this bleed. This is anteriorly posteriorly oriented. So this bleed is in the region of the Sylvian fissure.
Sir.
It is not a parenchymal bleed. This is mainly the subarachnoid bleed. This bleed should be differentiated from intracerebral bleed. So we should look for distribution along the Sylvian fissure. And in this case, the medial. Look at this basal ganglia structure. They are medially displaced. You can clearly see this lentiform nucleus, which is separately from this lesion. Okay. What is this 23 years male presenting with ataxia?
So, in the T2 flare images, we can see there is bilateral hyperintensities, T2 flare hyperintensities in bilateral cerebellum involving the nuclei, cerebellar nuclei, and there are subtle hyperintensities in the right side anterior part of the internal capsule, and also in the left putamen. So this would be white matter changes.
Okay. If you look at this sequence, this second middle image, what we see this hyperdensity, they are regularly seen at a uniform regular interval on both sides. So these are the pulsation artifacts. There is no lesion here. These are all artifacts.
What artifacts, sir?
Pulsation artifacts. So this patient came after 3 years with deterioration.
Sir, what about these white lesions in the cerebellum, sir, in the first image?
I will tell you.
Sir.
After 3 years, this patient presented with hemiparesis. Left side. Can you describe the finding in this?
So, in the 3 years later finding imaging, we can see in that flare image there is there are areas of hypointensity surrounding a perilesional edema, hyperintensity could be edema, and in the T2 image it is also looking the same. There is perilesional edema with some lesion maybe here, supposedly could be a mass lesion.
Mass lesion, but don't say much mass effect.
Because यहाँ पे perilesional edema है, and there are some.
I think Ajay, you should go ahead and describe the finding. It's not a simple case for him.
Okay, there is a node on the other side also. This is the established
putamen external capsule are also hyperintense, and posterior limb of the internal capsule on the left side.
So we'll see multiple microhemorrhages distributed on both sides, plus there are hemorrhages in the cerebellum. So this is a case of primary sinus vasculitis. Whenever I see white matter signal changes, which are not fitting any, they are bizarre, mainly in the subcortical white matter, multifocal, always think of vasculitis. Or these changes may start in the posterior fossa first, and then they progress. Or most of the time they are supratentorial, but maybe in the posterior fossa. Always do SWI in such cases to look for evidence of vasculitis. This is another example of vasculitis. These changes are mainly subcortical, multifocal, involving both sides with the multiple areas of hemorrhage distributed. If you give contrast, you will see punctate plus nodular enhancement. So this is classical vasculitis. The presence of microhemorrhages and dot-like and linear enhancement. Similarly, you can also have the involvement of the spine also. Like in this case of vasculitis, we see involvement of the spinal cord signal change, plus there's a peripheral enhancement. If you do DSA in these cases, on the venous phase, most of the time we see there's a puddling of contrast. We call it pseudophlebitis pattern. The venous stretches, they are not sharp, they are not very well defined. And then you can have also macro hemorrhages. Micro plus there's a macro hemorrhage, and the nodular type of enhancement is also described in the vasculitis. And then you can have perivascular enhancement, like linear enhancement along the blood vessels, perivascular spaces. So these are different patterns of enhancement. You can have dot linear enhancement, you can have perivascular enhancement, or you can have nodular enhancement. But most of these lesions are in the white matter, mainly subcortical, with areas of hemorrhage on SWA. Like this is a 34-year-old male presenting with SAH.
There is a hyperdense lesion involving the insular area.
Look at the Sylvian fissure on the right side and then compare it with the left one.
The Sylvian fissure is not.
Okay, so there is some hyperdensity there. Go ahead, next. Ventricles are enlarged.
Ventricles are enlarged.
Okay.
What about the next image?
These are the contrast images. What has happened to this blood vessel?
There is a concentric
Enhancement of the blood vessel. Okay, that is on the sagittal image also you can see the enhancement of the MCA branches. So this is a case of vasculitis. We'll see enhancement of the blood vessel in the Sylvian fissure, and there is a hemorrhage presenting as SAH. That is also one of the causes of SAH, vasculitis. This is a case of hemispheric vasculitis where changes are limited to the one side. So you can have diffuse involvement, but rarely you can have unilateral involvement. What are the imaging finding here?
There is multifocal narrowing involving the anterior cerebral artery.
Yes. Pericallosal and callosal marginal arteries are showing multiple focal areas of nodal artery. So this is vasculitis. And on the venous phase, in another patient, you see the vessels are not very well defined. It's a pseudophlebitis pattern, which is seen in so normal, if you see a normal MR in case of suspected vasculitis, that goes against the diagnosis of vasculitis.
So, okay, Ajay, can you ask you one question? This is from the audience. How to differentiate white matter changes in vasculitis versus demyelination?
In demyelination, the vasculitis lesions are mainly subcortical in location. They are ill-defined. Most of them, they are seen in the region of the MCA territory, or they are seen in the lower cerebellum. Like otherwise, on the other hand, the demyelinating lesions, they will be mainly involved in the deep central white matter like corpus callosum, pericallosal. They are periventricular in location, not in the subcortical location. And then if you do SWA, you'll see multiple areas of microbleeds plus macrobleeds. And the enhancement pattern, punctate and linear enhancement pattern, it is not described in case of multiple sclerosis. This way you can differentiate vasculitis from other demyelinating lesions.
Okay, go ahead.
Similarly, whenever you see a case of anterior circulation stroke, always look at your vascular flow wires in the region of the skull base and the MCA. Like in this is a case of Moyamoya disease. The MCA, you see multiple vascular flow wide in the region of the one segment. Plus you see multiple linear hyperintensity on the flare. We'll call it flare IV sign, which is suggestive of reversal of flow in the blood vessels. So this is an example of Moya. So these are the imaging findings described in cases of Moyamoya disease. You see multiple linear enhancement. On MR, you don't see the M1 segments. Plus on ASL, you'll see multifocal areas of diffusion, this hypoperfusion. And on base images, the major vessels will not be seen. In place of that, you'll see multiple vascular flow wires. On DSA, you will see this replacement with multiple left medial collaterals. What is the finding in this? This is
There is T2 hyperintensity is involving the bilateral keratooccipital region.
Whenever you describe a hyperintensity, always describe whether it is involving the cortex or gray matter, cortex or white matter.
It is predominantly involving the cortex.
It's involving both gray and white matter. So these are the PCA infarcts. So whenever you see a case of PCA infarct, always look for CV junction anomaly. Like in this patient is having baseline imagination, AAD, plus this patient is having one posterior PCA infarct. This was the DSA done, which was a dissection in the V4 segment on the right side. So remember one thing, whenever you see posterior circulation stroke, always look for CV junction. What are the findings in this patient?
So look at the CV junction, okay? And describe the findings, please.
What is this? This is cerebellum. The multiple lesions involving both sides. This is the SCA territory infarcts, which involving gray and white matter. This is the pica territory infarcts. So we see infarcts in multiple distribution.
So Ajay, you are left with only 2 minutes. If you can wind up, please.
So this is a case of baseline invagination with AAD and posterior circulation stroke. This was the angio done, which shows the occlusion of the vessel. Similarly, this example of multiple posterior circulation stroke with dissection. So summarize that CT is the important tool for the modern stroke triage. We look for areas of hemorrhage, look for other causes of the like brain tumors or other things which can explain the symptoms. Whenever then you see, look for the early ischemic changes, look for the extent of signal changes, and then find out the candidates, patient who are candidates for thrombolysis. In anterior circulation stroke, always look for flow wides in the region of the skull base to look for Moyamoya disease or other things. And in the posterior circulation, rule out CV junction anomalies. Thank you, sir.
So thank you, Ajay.